So thank you so much for joining us and for being with us in New York. So what we're going to do is we're going to have a fireside chat. Dr. Seshamani and I are going to speak for a little bit about some topics of importance, and then we will turn it over to the audience and we'll take some questions. So you may not know this, but those in the NewYorkBIO community know we host almost every Tuesday morning a fireside chat style virtual breakfast. And we started doing it during the pandemic. I think we're at about 130 episodes in, so a lot of time. And one of the things that we learned from our audience is that they want to know the background of the speaker. And it was something that I didn't think about. We thought we would just jump in, right, to your expertise area of your content. But it really resonates how you got where you are. So you're an ENT by training, but you're a health economist, you're a policy expert. Tell us what your journey was, how you ended up as the director of Medicare.
Well, again, thank you for having me here. It's great to be here with all of you. So I ended up a college and I did so I ended up majoring in economics. I doing my studies really wanted to be able to bridge direct patient care with how the market systems. So I did my PhD in economics. I've had the good fortune in my career to be able to bridge those. I led the office. I was leading care transformation in the area while experiences and to be able to bring to what policy.
The mic not.
Okay. I mean, I can take this off.
Yes, you can lose the
Oh, freedom.
I'm left to look like a news reporter.
I don't know, I can vote.
At 5 p.m. we'll have. So I have the incredible good fortune to be able to take those very personal experiences and bring them to bear as we think about larger, policy issues and where, we have the opportunity to impact the lives of millions of people, nearly 65 million people in the Medicare program. But also, I know Medicare is the largest payer in the country, $1 trillion in claims, partnering with 1 million clinicians, 6,000 hospitals. So where you make a change in the Medicare program, it really has ripple effects throughout the ecosystem. And that's a true opportunity and a responsibility. So being able to bridge, my opportunities practicing medicine, working, leading community health, programs, case management, alongside, being a policy expert, working as a health economist, it's really a unique opportunity. It is really unique. And I think it's from our standpoint, right, from the industry standpoint, we also appreciate that a clinician is also in charge of looking at the policies surrounding treatments, because that's really important. So talk to us about your vision for Medicare and how today it needs to address whatever you believe are the most pressing health needs of the Medicare population.
Absolutely. So I published a piece in January of last year on kind of the overall vision for Medicare and what are the strategic, pillars that we're really driving towards. Again, keeping in mind that changes you make in the Medicare program really do have that impact across the whole ecosystem. So starting with health equity, we all know the pandemic exposed a lot of what we in healthcare already knew about the disparities that existed in our society, and where can we really leverage the Medicare program to address those inequities. We have several examples of work that we have done to date in that, really focusing on how can we reward excellent care to underserved populations. So for example, we have this accountable care organization program where groups of providers can come together and
They can be rewarded for high quality and for keeping people healthy out of the hospital, so ultimately spending money in a smarter way as well. And, what we're going to be doing is that for those providers who are caring for more vulnerable populations, when they meet quality metrics, they get an additional reward, right? So that we can make sure that we are investing in those providers who are serving these communities. We're rolling out 200 new graduate medical education slots a year over 5 years, prioritizing rural and underserved areas. Again, really thinking about the Medicare program as a very powerful lever to really drive change, to move care upstream, to make it more holistic. Thinking about cultural competency, language access, screening for health-related social needs, requiring special needs plans in Medicare Advantage to screen for health-related social needs for their population. So that's one bucket. Looking at how we can expand access to coverage and care. There are aspects of the new drug law, Inflation Reduction Act, with the cap on insulin copay, $35 for a month's supply of a covered insulin product, will have a huge impact on people being able to access care. Vaccines, recommended vaccines at no cost sharing. Again, where are there opportunities to be able to improve access? And it comes back again to where can we support the workforce, the levers that we have to do so. We've also proposed in Medicare Advantage oversight around prior authorization, make sure that people can access medically necessary care. The next bucket is around innovation and how can we make sure that we're supporting high quality whole person care. And this is really where driving value-based care, really trying to provide, for example, upfront money for providers who need to invest in teams, in infrastructure, to engage in something like an accountable care organization. And then moving to being good stewards. Where can we really make sure that we are shedding light, having more data, more transparency, making sure that the market is working as well as it can, and that we're really driving towards ultimately what all of us want, better care, improved health of the population, and spending that Medicare dollar the best way to make that happen.
Okay, you covered like the entire paper that you published in like 3 minutes. So let's dig in just a little bit.
I am a surgeon.
Yeah. And I'm a lawyer, sorry. So we have to meet in the middle. So let's dig in a little bit. And I'm going to use an example. So talking about health equity. So one thing I think that was also exposed during the pandemic in particular, even though I think we understood it, but not to the extent, is the idea that certain groups were not comfortable seeking care and we didn't sort of reach them where they needed to be, right? So how, as a payer, right, can you incentivize the distribution of care where it's needed most, which is where the patients are?
Yeah, that's a great question. And actually, I'll start with my role before I came into the Medicare program. We had mobile primary care clinics before the pandemic that we were setting up. And when the COVID vaccine became available, we leveraged those mobile vans to go out into inner city Baltimore to primarily African American senior centers with community health workers to explain what the vaccine was and to help people get vaccinated. And that was in the early stages of vaccination. There was definitely a lot of unknowns, a lot of distrust, and we had a 2/3 acceptance rate at the outset with that. And I think that's what you were talking about the power of making sure that you are bringing things to that last mile. I say the Medicare program has, kind of 3 layers. There's the Medicare statute or the law at like 50,000 feet, right, that provides the overall guidelines of how the Medicare program works. Then there's the regulation that, we put out, the 25,000 foot level, right, giving some rules of the road, trying to support good care, right, break down barriers. And then there's how care plays out on the ground. And again, as someone who until recently was on that ground, taking care of patients, it's very important to me that we are partnering as we are doing all of our policies. Because you can make a great policy and everybody high five, great, we did a this huge regulation. But do the people who you intend to serve know about it? Can they access it? Can they understand it? And a great example is, we have the Medicare Savings Program, which provides financial assistance. to people of lower resources for Medicare. And when I came into my role, only half of people who are eligible for the program were enrolled. So it's a great example of where you can have a wonderful program, but it really is about that last mile and about the partnerships that we created through Medicare open enrollment. And in one open enrollment, we increased enrollment by 800,000 people. So, coming back to all of these great things that, I'm talking about, it's very important to me, number one, that we're engaging at the front end so that we can hear from people on the ground where gaps are, where are there opportunities for improvement, how to think through policies and operations of our program. And then as we are rolling things out, to do so in partnership with those same people on the ground, so that you make sure that you have trusted messengers and partners who are going to make sure that you're getting the most impact for the work that you're doing.
So in particular, and so one other step back. So at NewYorkBIO, we have a diversity, equity, and inclusion task force, which includes NewYorkBIO members and includes others from the community. I know you spent time earlier this morning at New York City Health and Hospitals. We have a representative from H&H that sits on our task force. And one thing that is unique about New York City in particular is that it may be fairly tight geographically, but it is really hard to make it from one end to the other. And so these barriers that we talk about, even like in rural areas, they exist against whatever you would think they exist in New York City for receiving care. So has Medicare provided any help or guidance, or do you have programs that help with getting the getting of the care, not just paying for the care? What are the surrounding things that you support?
Yeah, absolutely. So I will start with the paying for the care because that is an important piece, right, of how we can support how care can be provided. So just to give one example, where, again, using the pandemic, we learned how important it is to reach people where they are, right? That includes those who are the most vulnerable in the pandemic who are in their homes. So we increased payment for providing vaccines in the home so that you can better reach people. Where we can then take that, talking about these holistic care models, we can create a payment model to reward, team-based care, you meet quality metrics, you end up saving money, the Medicare program, because people stay healthy in their communities, you share in those savings. But I'm interested in taking it that last mile, where we have learning networks so that people can share best practices. How have they partnered with community-based organizations in an effective way? How can we make sure that we are, encouraging screening for health-related social needs and engaging the right kind of team to care for someone? So I think there's that component as well, again, of how we are facilitating, using our platform to facilitate different parts of the ecosystem coming together as well.
Talk to us a little bit, and you mentioned this briefly, value-based care. What does that mean for you? What does that mean for Medicare?
Yeah, so value-based care arrangements are essentially programs, care models that are looking to see people as people. Traditionally, it's been, someone comes into an episode of care, right? They've got a particular ICD-10 code associated with their diagnosis, an E&M code or a CPT code for what is done. Then they go on their merry way and you move to the next patient. And I think we all know that snapshot, 15 minutes, 30 minutes, does not summarize the myriad of experiences that impact someone's health. And it's really a focus for us to open the aperture and expand the scope of how we view healthcare so that you are meeting people where they are. You're meeting people where they are geographically, but also with what it is they need in terms of a partnership from the people who are caring for them. So it's not just about the doctor or the nurse. It's about the social worker. It's about the community health worker. It's about the chaplain. And so really being able to provide these kinds of models that enable healthcare providers to engage in a more team-based approach to care, where they can have that flexibility to engage outside of that episode of care and keep people healthy. And we have a variety of models, to encourage that. But at a high level, I think that is the vision.
So we in our audience, and for those in the audience, we shared with Dr. Seshamani and her team for the different patient groups that were here today. And so she knows that we have a lot of rare disease patients, and we're going to have a panel talking about rare disease later. So often with rare disease, a lot of the caregiving is on family or their unpaid caregivers. Talk to us about how Medicare helps support caregivers.
Yes, and I will say again that this is something coming from my prior, roles, working as a provider. One of the aspects of care that I led in my last role in care transformation was palliative care and geriatrics, both of which are really, caregivers are central. And we had, a social worker who would run, a weekly group for the caregivers of the patients of our healthcare providers. So in the Medicare program, there are several ways that we are seeking to support caregivers. First, some of these holistic models that I mentioned, like the accountable care organization, this is where, we want to enable providers to support the caregivers, because again, then if you can keep people healthy, you keep them out of the hospital, everybody stands to benefit, right? Having that more team-based holistic approach to care. We also have more specific, for example, we did a request for information last year on caregiver training. Can we pay the Medicare program for caregiver training, particularly around behavioral health training for caregivers? And again, it's very important, especially for people in Medicare who have dementia and have a caregiver, taking care of them. So we asked for comment on that last year to see, is this something that is possible? And when we're doing our intakes, particularly for people with dementia, there are specific questions around caregiving to understand what are the caregiving supports for that person. Those are just a few examples of where in our policies we are supporting caregiving. And it comes back to, a theme of what we're talking about, of, taking it to that last mile, where not only are we trying to create these programs or these policies or these payments, but working very closely, for example, with the Administration for Community Living, so that we can leverage the area agencies on aging with these care models, so that healthcare providers don't have to figure it out on their own how to support it. There is an area agency on aging that we can establish a partnership, help to facilitate that, so that people in the community can get the support that they need.
How common is that, right? Medicare is the behemoth, right? And how often do you and the agency go sort of beyond your borders to work with others? And how do you figure out what other organizations you need to pull in to serve patients?
Yeah, we work with our sister agencies all the time. So for example, again, when we're looking at expanding these holistic care models, working with the Health Resources and Services Administration, who administer a lot of workforce development grants. So we are saying, okay, we want to provide upfront investment dollars for providers in rural, underserved areas. People can braid that with workforce development grants coming from HRSA, so that you're getting funding for the community, for community health workers, for other types of providers as well. I mentioned the Administration for Community Living, and we work very closely with them as well, particularly on vaccines. So they do a lot of work in outreach for vaccines. And again, coming back to, you can have a great policy, but it has to go that last mile. What we need to do to have outreach around, now you can get shingles vaccine at no cost, tetanus vaccine, no cost. You can get your insulin, no more than $35 for a month's supply. So being able to partner on the outreach is very important. And it's even more tactical things, like we stood up a new provider type, rural emergency hospital, care in rural areas. And HRSA, our sister agency, has a network, well-established network of rural healthcare providers where they provide assistance. So we tap into that. We say, hey, can we come join one of your sessions so we can give some technical assistance for people who want to apply to become a rural emergency hospital? So we work very closely across.
And get your questions ready. I'm going to ask one more question, then we're going to go to the audience. That actually brings up, so I'm originally from Mississippi. those of you hear the accent, I know you're shocked. And I did notice there was an article I saw in my local paper just this week talking about community hospitals closing. So how does that put more pressure on internists or family physicians in those communities to be able to share information like you're talking about, like for vaccines and things like that? How do you bridge the gap when you're looking for more access for patients, but yet their structures are changing?
I mean, I think, and I can't speak to exactly the reason why a hospital closes, right? It's multifactorial. And I think this is where we constantly have to be in partnership with those on the ground to figure out where the gaps are and how we can best support. And how we can make sure that we are leveraging all avenues that are available, public health and traditional healthcare, hand in hand, to make sure that we are reaching, the people where we need to reach them.
All right, questions? Luke, I know you're loud, but let's bring a mic so everybody can hear it.
But I know, there. Forget about, of course, patient care, about how cost effective next generation sequencing and testing is. And correct me if I'm wrong, but Medicare covers cancer related sequencing. And I'm wondering how far away are we from Medicare covering whole genome and exome sequencing for diseases outside of oncology and cancer?
Yeah, and I'll say for that, basically there are things that are in the Medicare law. Where there is flexibility and discretion in the Medicare law, then those are things that we can definitely look at. And so this is where it's so important for us to be able to engage and partner with all of you to see, okay, where are there opportunities? What is the evidence? So we can evaluate where we have the authority in the law to pay for something. Is that something that should be paid for? How should it be paid for? That I wish I had a crystal ball. I do not have a crystal ball. Well, I think, part of it is seeing what is allowable under the Medicare law and then being able to engage and say, okay, what is the value that this is bringing, right? Who's using it? What is its purpose? And to be able to, provide that to then see, is this something that can be repaid? And I also think this is where, these care models that I'm talking about present a really great opportunity for innovation, where if you have something that is going to identify, say it's going to prevent, diseases or identify even earlier, in the process, being able to engage with those, okay, we want to improve quality, we want to keep people healthy, right? And so engaging in that way as well is our hope with, supporting and expanding.
And this is where I plug the NewYorkBIO obviously works with all of you. We work with our member companies. We advocate at the federal level in Washington. We advocate in Albany at the state level. So our working closely makes sure we're aware of things that are important to the patient community so that when we're in front of legislators, we can make sure we're raising these things that will move the needle. Loretta.
I think you mentioned area agencies to serve communities. Did I get that right? Can you talk about that a little?
Yeah, so area agencies on aging are run through grants with our sister agency, Administration for Community Living. And they provide a lot of support for older populations in the community. So, for example, providing caregiver supports for food and transportation to doctor's appointments, things of that nature. So we partner very closely.
And the question was, how do communities find out about those resources?
The Administration for Community Living has a website that lists where all of the area agencies on aging are. There's probably a phone number there too, to be able to find out more.
Others? I know this group is not shy. Okay.
We've talked about so much about the aging population, but what about the young patients who can't even receive a diagnosis, which so much of the time fall under rare disease patients? And right now, in order to obtain a diagnosis, you most likely have to go under whole genome, whole exome sequencing. But the way it's structured right now is it's a state by state fight to get that type of testing for critically ill patients in the NICU, PICU. Do you have any ideas on how we can improve that process as a nation and not state by state?
Thank you for the question. I mean, I can't speak to that directly because I work in the Medicare program, so I'm not working, at that state level for, NICU and PICU. What I will say more generally is, this is where it is very important for people's voices to be heard, where there is an issue, and to say, hey, and also to come forward with, here are some potential ways to address it, right? To be able to engage. Well, I will say that a lot of times that comes down to law, where, if there is a federal law versus if it is, a jurisdiction by states. Whereas where the work that I do is more on that regulatory level. So where the law gives the authority, then, we work on the regulation.
Right, so the administration will enforce or issue regulations and basically put into practice the laws that Congress passes. And one thing too, so Medicare obviously is for older Americans, but it also covers certain disabled
That's right.
patients, right?
Yeah, so, I mean, we do have births in the Medicare program, and because we have a stage renal disease and disabled population.
Other question? I think we have time for one or two more.
I had a question in regards to Medicare. There seems to be a trend of more as opposed to traditional Medicare to be more Medicare Advantage plans. Is that a preference by the administration, or what drives, outside of the private sector for Medicare Advantage, what is driving that push?
That's a great question. So there are various parts of the Medicare part. There is traditional Medicare, fee-for-service Medicare, which is Part A for institutional care like hospitals, skilled nursing facilities. B, which is for, more clinician services. And then you have Part C, Medicare Advantage. You have Part D, prescription drug coverage. And then you have, supplemental insurance for those in traditional Medicare. And I really view all parts as important pieces of the puzzle for the overall Medicare program. So really what matters to me is that people are able to navigate and choose the option that works best for them. For some people, it might be traditional Medicare. For other people, it might be Medicare Advantage. There are pros and cons to each, and it very much depends on one person's particular situation and what their needs are. And I think to that end, what you'll see in some of the policies that we're doing is trying to make the system more navigable. So for example, we've proposed in our recent Medicare Advantage regulations to have increased oversight on misleading marketing practices, where there's misleading marketing practices that can lead people to maybe enroll in a plan that wasn't necessarily the best plan for them, or where people get switched from one plan to another and they didn't even realize they were changing plans. And then they wanted to see their doctor, and their doctor said, well, I'm no longer in your health insurance network. And they say, wait, I changed health plan? I mean, these are stories, again, the importance of engaging on the ground. These are the stories and the experiences that we hear that people say, hey, can you do something about this? And so we made several proposals, for example, that health plans and, brokers can't use the Medicare logo, or something that's similar to the Medicare logo in misleading ways so that people actually think it's Medicare. No, it's coming from a private health plan. So we made a variety of proposals like that to, again, try to, achieve where everybody can have that opportunity to really, truly pick what's best.
We have time for one more question. We have one. Loretta, anyone? Oh, wait, sorry, we've got one back here. Yeah.
Thanks. I have a pretty loud voice, so this wasn't necessary. I'm a physician who left medicine many years ago, and I am unfortunately over 65. Unfortunately, I've gotten it. Medicare in New York is quite an experience. I've had my physicians withdraw from Medicare. I've had physicians who I want to see as specialists who don't take Medicare. Psychologists don't take Medicare. And I'm wondering I can't nationalize this perspective because I haven't lived everywhere and I don't study this, but my perspective is, and having taken care of my mom, who was on Medicare for many years, she lost her legs in an accident in the 50s, I am very concerned that there seems to be a flight of quality physicians away from Medicare. I'm sure it's part of the larger picture, but I'm wondering what is your perspective on this? I don't know that value-based care is going to motivate these docs to take on. And the one thing that also surprised me is that, correct me if I'm wrong, but they cannot have a practice where they take only some Medicare patients, not others, or continue with their older Medicare patients until they, age out of the system, so to speak. What is the perspective of CMS?
Yeah, thank you for that question. The data shows that we have 99% of physicians in this country participating in the Medicare program. Every year, we do engage and say, hey, are you interested in participating? We provide information. We also have things like the Medicare Learning Network where we disseminate information, education for providers that they can use with their patients. So, we do what we can to encourage people to participate. We do have pretty robust participation across the nation. And I think overall, we're all aware of the burnout that has occurred with the healthcare workforce. And, we're looking in the Medicare program of what levers we have to try to address that. So prior authorization is a perfect example where we heard from providers about the burden of the paperwork, prior authorization, the frustration in people feeling they cannot provide the kind of care that their patient needs. And we took all of that into consideration. And, we made proposals around prior authorization for Medicare Advantage to have clearer rules of the road. We also have a regulation to streamline prior authorization, to have it be electronic. You have to have a turnaround of 72 hours or less. You have to have more transparency in terms of the data of denials. So trying to think through where we have levers the Medicare program, again, not knowing that one piece of the puzzle is not going to solve the problem of workforce shortages or burnout, but where we have levers to really try to, to put our shoulder to the wheel to try to address some of these workforce issues.
Well, we are glad that you were here with us to address our community and to talk the things that are important to the NewYorkBIO community. So thank you so much for your time today.